IHI community, please welcome Chief Quality Officer, East London NHS Foundation Trust, Dr. Amar Shah.
Hello and welcome to the final keynote address of this year's IHI Forum. And as usual, we've saved the best till last. My name is Amar. I'm a physician and chief quality officer at East London NHS Foundation Trust, one of IHI's strategic partners. So, have you had a good forum? How amazing has it been to be together again, surrounded by people who are so passionate about purpose and committed to improvement and who have such a feeling of love for each other. For me, the true test of the success of the forum is whether I've lost my voice or not by this stage. And it's not got much left to go, so I'm going to keep this introduction really quite short. The person I'm introducing you to really needs no introduction at all. It's hard to think of anyone more deserving of that description than Don Berwick. It's been more than a decade now since Don stepped down as IHI's first chief executive to run Medicare and Medicaid under President Obama. And since that came to an end, IHI has benefited tremendously from his continued and close engagement, from the number of projects and initiatives he's involved with, to the Leadership Alliance, to the board of directors of IHI. Many people have referred to Don as the conscience of healthcare, a description that I imagine makes Don feel a little uncomfortable. But I don't think it's off the mark. In the early days of IHI, when Don was demonstrating the power of improvement science to transform how healthcare is delivered, he was driven by the why. For Don, improving care delivery in the service of better health is a moral responsibility for us. His eloquence in making the case that improvement was the right thing to do has compelled millions of us to take up the charge. I'm sure you, like me, have been inspired by Don countless times. In the 30 years since Don founded IHI, the circumstances of our work have changed. Even in the last 3 years, they've changed dramatically. We are society's healers, the stewards of health. This responsibility now compels us to look at every aspect of how we work and what we work on. The promise of quality improvement has been realized inequitably, and our health systems still draw too many resources from other parts of society that are even more essential to good health. Our responsibility to our patients, to our workforce, to our communities has never been more urgent than it is today. And I'm sure I'm not alone in feeling grateful to Don for keeping us all looking and moving forward. Now, please join me in welcoming your final 2022 IHI Forum keynote speaker, the incomparable Don Berwick.
Thank you so much, Mar, and thank you all. This has been just an amazing time to be together with you finally after 3 years. I knew it would be good. I had no idea how good it would feel. And I'm looking forward to much more time together. What an extraordinary community. It is an odd time. It's a paradox. There's so much to celebrate as we are here, but it is in the midst of the tragic loss of 1 million American lives to COVID, 6.6 million globally, and so much of that loss needless. I don't think ever before, except maybe in wartime, has so much been asked of the US healthcare workforce and around the world, and the entire workforce. And they rose to the challenge. They're battered, exhausted, sometimes depressed. Our doctors and nurses and pharmacists and therapists and managers and technicians and all staff, they showed up, they suited up, they did their jobs, they saved people, they eased pain. They were the healers that they had pledged to be. And they did it against barriers that should not have existed. Shortfalls in equipment, misinformation, lack of proper national infrastructures, but they did it anyway. I think this exhibit of human spirit and professional dedication warrants pride and gratitude, and it will for the next 100 years. And in a way, we did it too. I'm deeply moved by the stories I've heard of those in the community of improvement, us, who stepped up, suited up, did their jobs. As one example, I'll embarrass Jason Leach, close colleague and friend, an IHI former fellow. He's an example of the improvement community stepping up to take the ball. Jason became the head of the COVID response in Scotland and brought his technical skill, what we're celebrating here, his incredible communication skills, his political savvy and gracefulness, and save lives. I think when the annals of COVID are finally written, Jason's going to stand tall among the pathfinders. But he's just one example of members of our community who got engaged, used their skills, and brought us to help. In that aura of loveliness, it is hard to bring attention back to unfinished business, but that's what I'm going to do today. It's for no other reason than this. It's that the workforce, the people who rose to the occasion, they deserve better. They deserve political, economic, spiritual, emotional context, supports that nurture and respect what they did and what they do. And that, sadly, is largely not today's context, and that needs to change. It's early morning, and Julia Crane, the hospital CEO, she is driving into work. Her mind is already a whirl with what awaits her. The basics, of course, are just running a hospital, budgets, personnel, scheduling, market strategies, program choices, so on. That's a massive job. It's the job she thought she had. But nowadays, there's a deluge of demands on her that take her time and that she never saw coming when she signed up for the executive role. Climate activists are demanding that the hospital decarbonize. Recently published data on racial disparities in local areas, her area, and disparities in outcome have brought anger about inequity and structural racism to a local boiling point. The pandemic, of course, has left Julia's staff exhausted. Resignations are at an unprecedented level. There's a shortage of nurses that's forcing some units to close. Many nurses have found relief and higher wages by becoming travelers, which means that the hospital, which is already starved for staff, has had to hire back in temporary roles at higher cost the exact same people who had recently resigned from full-time work. There was a newspaper story last week about surgical mistakes, and that has reignited worries about patient safety. The government is demanding more work on preparedness for the next pandemic. Primary care clinicians and community groups have become louder and louder about social determinants of health. They are demanding that the hospital respond by funding food clinics, housing supports, more mental health services, more in-home care. Julia, the CEO, she's paid well. Her salary and bonuses are in 7 figures. And she serves on 2 outside corporate boards. Each gives her stock options and a 6-figure stipend. But that too has become a problem. A newspaper expose attacks the propriety of big salaries and potential conflicts of interest in Julia's compensation package. Julia has to face her hospital board, her employer, tomorrow. COVID-19 took a bite out of inpatient occupancy. It's raised supply chain costs and it's forced salary increases. And at the board meeting, Julia is going to present the largest budget shortfall in the hospital's history, and they, the board, they're going to expect her to fix it. A merger is always possible. It now seems closer than ever, and Julia's future in that is uncertain. She has never, ever felt so stressed. To be honest, though, Julia has felt confused for a long time, for years. It hit her 3 or 4 years ago in 2019, just after the management retreat day that she led before COVID arrived. In the morning program, Julia talked about integrated care, social influences on health. She said the hospital had to transform itself to become a more effective community resource, that the hospital was there to keep people healthy. Then in the exact same afternoon, 2 hours later, with the exact same audience, she gave her annual report on hospital finances. She celebrated volume, rapid increases in surgical throughput, high occupancy rates. She celebrated more MRIs, more PET scans. They beat their revenue target. It actually didn't dawn on Julia until she was driving home that night 3 years ago that those two presentations were completely contradictory. They were schizophrenic. In the morning, she celebrated less hospital use, and in the afternoon, she celebrated more hospital use. What did she really want? It's the same morning, and George Evans, who's a primary care doctor, dresses and he heads in for the clinic. As he drives, George is thinking about the patients he's going to see that day. He's thinking especially about Dora Adams. He can't stop thinking about her. Mrs. Adams has been having more trouble breathing lately, and none of the easy explanations have panned out. It's not asthma, it's not an infection, it's not chronic lung disease. No, Mrs. Adams is a vibrant 59-year-old with a grandson's graduation just around the corner. But she's going downhill, and George does not know why. Today, Dr. Evans will have 15 minutes with Mrs. Adams, if he's lucky. There's never been enough time, but last year his practice group was acquired by a division of an insurance company, joint venturing with private equity. And George has noticed some new pressures on top of the old pressures. Everyone has been asked to see 2 more patients per work session. And productivity reports are circulated back with thanks if George hit his target, or a gentle reminder if he has not. He's also noticed something strange. His records are now being reviewed by people he never met, so-called coding consultants. They ferret out diagnoses and they recommend tests that he hasn't chosen to record or to order. He hasn't because he didn't think they would help or make a difference. Actually, they don't make a difference to the patient. They do make a difference to the bill that the owner sends to Medicare. George is 63 years old. His father had a small farm. His mother was a bookkeeper. They were very proud of him. He was the first in the family to go to college, and they absolutely glowed on the day that he graduated from medical school. He used to love the work. Helping Mrs. Adams really matters to him. But as he drives, George is having some familiar second thoughts. He's thinking, it used to be fun, but it's not fun now. I don't even really know who I'm working for anymore. He's worried that he won't be able to give Mrs. Adams the time she needs today, time to figure her out, to answer her questions, to call her daughter, to check in with a pulmonologist. None of that scores as productivity on his scorecard. What's scorecard anyway? George asked. When did I sign up for a scorecard? He says, maybe it's time to cut back. Dr. Evans has never, ever felt so stressed. Dora Adams won't be driving today. Instead, her daughter's going to pick her up, which is wonderful. She loves every minute she gets with her daughter. But it's becoming an effort even to get dressed in the morning. Mrs. Adams pants as she bends over to tie her shoes, and her right shoulder stabs when she tries. What does that mean? Well, Dr. Evans will know. She trusts him completely. But she's worried. The last time Dr. Evans ordered a test on her, which was a special scan of some sort, it took 3 weeks before the insurance company, or whoever it was, she's not sure, approved it. And that was after she had to wait 3 weeks for her appointment. Dr. Evans was solidly booked up, and she does hate to bother him. The whole insurance thing worries her. She recently sprained her ankle on vacation. She went to the local emergency department. She got a bill 6 weeks later for out-of-network services. She doesn't know what that means. And the bill was $2,600. All they did was an x-ray and an elastic bandage. It'll take her a full year to pay that off. She's a school teacher, and she has a high deductible insurance plan. It was all she could afford. because for Dora, healthcare is essential for her future, but it's a financial minefield. Dora feels more stressed about that than she has ever felt before. I could describe others. They're all worried about healthcare. The small business owner whose employees' health insurance rates went up 30% in the past 3 years. She is drowning. The state Medicaid director, for whom soaring drug prices preclude any creative investments in prevention and social care. There's the aging nurse who just cannot believe the amount of time that she has to spend keeping records that absolutely no one will ever use. Pure waste. There's the radiologist whose practice was bought by investors and who came to work one day to find a sort of flashing light metronome in the reading room ticking off the tempo at which he was now expected to read films. I could talk about the famous teaching hospital that this year required all primary care clinicians to view a 40-minute video program on coding of diagnoses, urging them to make sure to add diagnoses to patients' charts and to make sure that they use the exact wording that would yield the highest Medicare reimbursement. The goal, said the white-coated teacher on the video, the goal was to assure that the hospital had all the resources it could garner to put to the service of patients. No mention was made that that hospital already had by far the highest unit price in the whole state, more than double the median, nor that it has the highest margin and the best balance sheet in the state. Now, these stories are disguised, but they're true. They are actual accounts from real people who have spoken to me or emailed me or have been written about in the press in the past couple of years. COVID made it worse, but these are not COVID stories. They are stories about the way the American healthcare system today, the system we're all here trying to improve, is working or failing to work. The names are disguised, but the facts are not. Now, I want to be careful when I speak to this forum. I always try to be. It's such a privilege to be here with you, to see the smiles, to really celebrate what we're doing together. It's wonderful. The workshops, the posters, they're full of very different stories from the ones I just told you. They're stories that we can and we should feel proud of. Bravo. Step by step, project by project, you're making care better for people. You're using the sciences of improvement to save lives and to create joy. The forum is a high point of my year, and it has been for over 30 years. But you cannot solve a problem that you cannot name. Patient safety improves after we understand patient injuries, not before. Pressure sores decrease after we count them, not before. Equity will improve only if and when we stare inequity in the face, not before. So, as improvers, let's investigate the distress of Julia, the CEO, or George, the doctor, or Dora, the worried patient, just like we'd look at an infection or an indignity or a delay. Let's excavate for causes. Why? Why in a nation as wealthy as ours, spending 1/5 of our economy on care, nearly twice any other country, overflowing with inventiveness and scholarship, why in American healthcare is there so much distress, pressure, pain, and fear? What happened to joy and confidence? What happened to the celebration of real success? What happened to progress toward health that's better than we've ever seen before? What happened to Julia's pride in being a leader, and George's joy in being a healer, and Dora's confidence that she will get and she can afford the help that she needs? What is bankrupting us, individuals and governments? We seek a cause, and maybe that search for cause can open a door to some remedy. Let's take a trip together. One morning, In the year AD 79, just a few months into the reign of the Roman Emperor Titus, Mount Vesuvius, looming above the Bay of Naples and the small coastal city of Pompeii in Italy, erupted. There had been several days of earthquake rumblings, and thousands of Pompeians had fled the city, carrying what they could. But thousands more were about to be buried by 8 feet of ash fallout, like a massive snowstorm as the mountain blew up. About a half day later came a cataclysmic pyroclastic eruption that rained super hot gases and searing ash down on the city, incinerating everything, including human bodies, and adding 8 more feet to the covering of the city. That's how Pompeii lay, buried and encapsulated under 16 feet of ash and pumice for 1,600 years, until the earliest archaeologists in the mid-18th century began to explore what was underfoot. Today, Pompeii is the site of one of the largest archaeologic excavations in the world. This is a scale model at Pompeii. Almost 2/3 of the city had been uncovered by now, over 100 acres excavated. I have long wanted to visit Pompeii, and this year in September, I got the chance. That's me in the Forum. In the 8 hours I had in Pompeii, I could visit barely a tenth of the houses and taverns and bakeries and stables and government buildings, temples, shops that had been uncovered. I imagined the people, now ghosts, and I stared at the very same frescoes and mosaics that they stared at in their lives. Hints of real life are everywhere. There are carbonized loaves of bread still in the ovens, piles of coins collected in the tills of the bars the day before, drinking mugs, tableware, children's doodles, graffiti, and election slogans painted or scratched into the walls, stashes of jewels that fleeing householders crammed into chests hidden for their return, but they never did return. Hundreds of houses have been excavated in Pompeii. Each of them is named now for some clue as to who might have lived there, or for some special piece of art: the house of the tragic poet, the house of the faun, the house of the golden cupids, the house of the surgeon. The streets, which are beautifully paved with stones, have ruts carved into those stones by the wheels of the carts that rolled over them through the 6 centuries that Pompeii existed before Vesuvius covered it up. Most striking of all, what you think about night after night after night after you visited, are the plaster casts of the victims. There are over 700 of these in all so far. Some are left in place exactly where the victims, men, women, children, even animals, fell and were found. The bodies are gone, but the pyroclastic flow, that intense heat, had just enough time to harden around the bodies before they disintegrated, leaving an exact mold of the person trapped. In 1860, Giuseppe Fiorelli, who was director of excavations at the time, he figured out a way to inject plaster of Paris into these cavities, creating exact statues of the people in the exact positions in which they died. On some, you can still make out the facial expressions of their last gasps. They are almost unbearable to look at, but you can't stop looking. What were these people doing before the world fell in on them? What seemed important to them? What mattered? What had they wished for? I visited the house of Siricus. The owner was probably a merchant, probably a big deal in town. The house is very large, very opulent. The mosaic floors and the frescoes are elegant, beautiful. And one mosaic, which is inlaid in the floor at one of the entrances to the house, contains a slogan in very big letters. Salve Lucrum, it says. Welcome money. Hail profit. I guess that was important to Mr. Sirikas, probably right up until the day he was incinerated. Actually, we don't know if he died in the eruption or ran out of town when the earthquake started. Either is possible. What we do know is that there are 5 skeletons in his dining room, and they're not of Pompeians from 79 AD. They're from thieves who tunneled into the house a long time later and then died when the roof caved in on them. Salve Lucrum, they might have said, just before they were crushed to death. I think Salve Lucrum might not be an inapt slogan on the mosaic floor of much of American medicine today. And I want to interrogate it on behalf of Julia and George and Dora as a suspect, one root cause of failure. So I will call some witnesses. With my colleague, Dr. Rick Gilfillan, I've been devoting a lot of my time over the past 2 years to trying to understand the unbelievably complex structures and financial flows of Medicare Advantage plans, which are growing very fast, now covering half of all Medicare beneficiaries. This is the privatization of Medicare. It's the movement of public dollars through private insurance companies. Now, the original intent 3 decades ago was to build on insurers' skills to better manage care, but that is not what happened. The result has been enormous extra costs as taxpayers and traditional Medicare beneficiaries have paid a bonus to those insurers, which will amount in the next 8 years, according to health services researcher Rick Cronick, to $600 billion more than traditional Medicare. Today, Medicare Advantage is the primary engine of profit for many major US insurance companies. Now, Julia knows that her hospital has to play that coding game that insurers use to make profit. That's why the hospital is training the primary care doctors with that 40-minute video. George's patients are being upcoded by agents that are deployed by the insurers. And although she isn't yet on Medicare, Dora's troubles getting approval for what she needs reflect insurers' oversight as well. Salve Lucrum. This October, Kaiser Health News reported the story of a patient charged $73,800 at the University of Chicago for 2 injections of Lucrum Depot, a treatment for prostate cancer, a drug available in the UK for $260 a dose. Salve Lucrum. The Employee Benefits Research Institute reported in 2020 that hospital prices for the top 37 infused cancer drugs averaged 86.2% higher per unit in hospitals than in physician offices. Recent New York Times investigations have reported on nonprofit hospitals reducing and closing services in poor areas while opening new ones in wealthy suburbs, and on their use of collection agencies for pursuing payments from low-income patients. The Health Policy Commission in Massachusetts reported 2 months ago on upcoding in Massachusetts hospitals over more than a decade and on rapid increases in hospital prices and revenues, almost 4 times the rate of inflation. Bloomberg Media listed the 10 highest paid executives in America in 2020, not the 10 highest paid healthcare executives, the 10 highest paid of all executives. 3 of the 10 were from Oak Street Health, an innovative primary care company that employs physicians and plays heavily in Medicare Advantage. The CEO got $568 million, the COO got $356 million, and the CMO got $221 million. Salve Lucrum. Mergers and acquisitions continue in healthcare. This is some information on some recent big money deals. Oak Street had a $15 billion initial public offering. That's equivalent to $196,000 per person in their panel. 2 coding companies sold recently for a total of $15 billion. Hospital consolidations are rampant. And the biggest employer of doctors today is Optum, a subsidiary of United Health Group, the insurance company. There are a few conclusions in empirical economic research that are as widely agreed upon as this. Mergers almost never yield the cost savings that the parties promise. On the contrary, mergers concentrate power, which the parties then exploit to raise prices. Mergers raise costs. Salve Lucrum. So what are the consequences of this? 41% of American adults, 100 million people, are bearing medical debt today. 1 out of 8 owes over $10,000. 2/3 have put off care because of cost. And as of 2021, 58% of all debt collections in the US are for medical bills. 17% of the people in medical debt say that as a result, they have had to declare bankruptcy or lost their homes. Health insurance premiums in my state, Massachusetts, have gone up over 200% in 2 decades and are now per family annually more than the price of a car. And more of that toll is coming right out of the pockets of people like Dora, who are forced to have high deductible plans. Now 20% of Americans have health care bills in collection. Now 46% of adults in my state, Massachusetts, say that they skip needed care because of costs. 46%. A mother is traveling to South America, and she goes to an academic New York City hospital, pediatrics, infectious disease department clinic to get yellow fever and typhoid shots for her 3 children. Her insurance company notifies her then that she is responsible for paying $2,828 per child, a total of $8,477. She calls the hospital to ask if that's a mistake, and somebody calls back leaving a message. I checked with the billing office. The charges are correct. Would you like to start a payment plan? After 45 days of appeals to the insurer, the bill's reduced to $649 per child, $1,946 in total for 2 shots each for 3 kids. At the San Francisco Department of Health, by the way, the yellow fever vaccine would have cost, instead of $2,444 at the New York hospital, $149 per child. If this isn't insanity, I do not know what is. I think this is wrong. A 40-year-old breast cancer survivor with 3 children is told 4 years out that she has a mass on her screening MRI that requires a biopsy. She's referred to the hospital outpatient department for the biopsy, and she waits. It's a time of terror for her. And after 1 week at last, there's good news. The biopsy is negative. But then there's bad news. Over the next month, she receives the bill that you're seeing here on this slide. The amount owed is $3,034 out of a total charge of $22,357. Understand that the median savings balance for an American family today is just over $5,000, and 35% of Americans have less than $1,000 in savings. You are looking at a potential bankruptcy. One doctor friend of mine, a primary care doctor, writes me an email. We have a new system, he says, driven mainly by the number of patients on our panel, not by visits. And since I said I was willing to take care of patients of several of my colleagues who've left, turnover's a big quality problem, my panel is now full and overflowing. The only problem is I have never provided worse care. The next appointment to see me is in February. There is someone in this room, a friend of mine, who I didn't know this story about, but my friend sent me an email after reading the speech, and I decided to quote it to you. This is from someone maybe sitting next to you. I am the child of medical bankruptcy due to a life-threatening car accident that my mother had when I was 2, which led to neurologic issues she has had my whole life. Both that one health event, teamed with the poverty we experienced for many years due to medical debt, has shaped my entire life in nearly every way. It was a large part of my calling to health and healthcare transformation, a testimony to how a system of greed in healthcare shapes generational poverty. I am one of the only family members that was able to escape that through my life path. It's no wonder that Julia Crane, the CEO, feels torn. No wonder that George Evans, the doctor, feels morally at sea. No wonder that Dora Adams feels scared. They are all trapped. They are trapped in a financial landscape that feels insane because it is insane. The pursuit of wealth now dominates the political economy of American healthcare. It is clothed in celebratory garments, justified as spurs to innovation, competition, hard work, the American way, and risk-taking, but mostly it is none of these. It is exploitation of power, games of arbitrage, lack of discipline, and ignoring externalities. It is get what you can now, get more, raise prices over and over again. Salve Lucrum. The American healthcare industry is, I strongly suspect today, the largest machine for the regressive transfer of wealth from the poorer to the richer in the history of our nation. The accretive power of American healthcare hurts many, it hurts most, of the good people who want healing, not money at the center. It traps them. It traps Julia, forcing her to divert her leadership and management skills to the continual pursuit of revenue. It traps George, turning his attention away from what fills his heart. It traps Dora, who can't understand or cope with the bills and the delays. It lies at the center of what Kedar mentioned about Wendy Dean and Simon Talbot's pursuit of the concept of moral injury years before COVID tightened the screws. Salve Lucrum. Guilty as charged. If we in this room care about improvement, and I don't doubt that for an instant, we cannot run away from this problem. Greed, the pursuit of profit for its own sake, driving the monetization of healthcare. Growth, acquisition. It is the healthcare enterprise's equivalent of climate change, relentlessly eroding the foundation of success, which is the shared pursuit of the mission of healing. I absolutely know the mantra, no margin, no mission, but I will tell you that slogan deceives us. In the long run, I think margin, lucrum, is not a cause, it's an effect. The sustainability of the enterprise that we love, healing, is in the long run the effect of doing what we do well, on behalf of, solely on behalf of, entirely on behalf of the people and the communities that we serve. Pocketing what we can get away with, raising prices to the very edge of what good people can afford, moving hundreds of billions of dollars from the shared commons to the owned, gated communities, playing games with numbers and bills and codes and delays, and fighting against the reforms that put resources where they are most needed. These may be tactics for quarterly returns and quick wins, but they are not strategies for a long-sighted people or a reliable future or a civilized nation. Not no margin, no mission, no healing, no mission, no equity, no mission, no sharing, no mission, no science, no mission. We will harvest from what we give, not from what we take. Now the politics of this, of course, are dreadful. The incumbent forces, the Salve Lucrum troops, they own the means of lobbying and public relations and legal representation, and indeed they have very suitable pride in technological competence, what they have accomplished technologically. And I want to be clear about that. Technical progress. Nobody can gainsay the victories of today's organ transplants, actual drug breakthroughs, medical technologies, vaccine development. My own wife went through open heart surgery 4 months ago. She's perfectly fine now. I am deeply grateful for the technology. These are crown jewels. We absolutely have to preserve them. We have to extend them. But they are crown jewels in a crumbling castle. In the end, if the building cannot stand, then neither can its contents, and this healthcare system, the economy we have built, cannot stand. Ask Siricus, the Salve Lucrum guy, what did he clutch in the end? Among the most affecting casts in Pompeii, to me, are those of small groups, a family of 3, 2 lovers, a mother and child clutching each other. Nobody died hugging their money. It's important to realize that when greed shapes the rules, that creates a vortex that others cannot resist. If Julia Crane, the CEO, tries to swim upstream, if she refuses to play the game of coding and pricing and market consolidation, she would lose. She has to play the game as a matter of institutional survival, whether she agrees with it or not. That's the source of moral injury. It's the same for Dr. Evans. Play the game or get out. The only solutions that can work are common solutions. Forbidding free riders, forbidding defectors. That's the nature of a commons problem, by the way. It is in shape identical to the struggle against climate change. Economists refer to externalities. Those are important costs that are not included in the price. They're costs that somebody else pays. Climate change is an externality from the viewpoint of fossil fuel prices. It's not in the price of the fuel unless we choose to add it through tax policies. And until it is in the price, the earth burns. The external effects on healthcare of greed and pricing games lie in the erosion of the integrity, vitality, spirit, and sustainability of our search for health. Some win. They win big. They win money. But many, many, many others lose. And in the long run, chaos wins. If we do not control the dominance of financial forces in healthcare, we will lose healthcare. The problem of greed is so big that I have trouble finding purchase. Here are some of the elements we might start with. First, we need to make noise about this. Professionals in healthcare, all types of professionals, need to speak out loudly in protest against greed. Profiteering and short-sighted deal-making ought not to be met with silence, but rather with concerted, relentless, unified communication to the public and to policymakers. Silence is assent. We must dissent. We need not attack the individual's behavior here. That is not my point. But the systemic support of these behaviors must end. We professionals need to say, this is not us, and it should stop. Extortionate drug prices, exploitation of market consolidation, coding games, promulgating unnecessary care. This is not us, and it should stop. Those bills for those kids' vaccines are crazy. They are lunacy. They are wrong, and we need to say so. I would like to see a vast social media campaign take form. It would be driven by the clinicians of America, calling for an end to the monetization of healthcare, an end to the unbridled profit motive as central to how we run healthcare in our nation. A call for return to mission as the core of care and care systems, a call for the termination of greed, the intolerance of greed in the healing enterprise. Now, to call for that, second, we professionals in healthcare, we have to lead by example. We need to insist that our guilds and our trade organizations demote the pursuit of higher payment among their strategies and activities, at least for a time. Their shared power should lean into insisting that resources flow to the neediest in society and that the protection of patients, all patients, is the first and highest calling. Now, this does involve policy and politics. Healthcare leaders and professionals should lobby Congress directly to pass legislation to rein in greed, reforming patent laws, changing coding and billing rules, strengthening antitrust enforcement, expanding price transparency, accelerating global budgets for the care of populations. Those are all statutory changes that have languished without strong action in Congress for years because the lobbying might of incumbents dries out the voices of the greater public interest. We who care about improvement should create new winds that blow right. We need to fill the sails of the political leaders who need to act to prevent the loss of our healthcare system. Fourth, I want to reiterate the call I made at the forum last year. It's the call for hospitals and healthcare systems to adopt the 10 Teams campaign, now 11 teams with the addition of programs to reduce gun violence. The 11 teams. Professionals within those organizations, you, should insist that your systems engage actively with every single one of these true causes of illness. If our incumbent hospitals bring resources to the true causes of illness, injury, and disability, that would be an unequivocal statement of intent that acquisition is not the purpose of the healthcare system. It would call the question in ways that others could not ignore. The forms of acquisition currently in control, Salve, Lucrum, will in the end harm health. They will not improve it. Health is a public good, and it needs to be pursued as a public good. Healthcare is a human right, and it needs to be secured as a human right. I recall a dinner that I had some years ago, maybe 15 years ago, with the head of New Zealand's healthcare system, I think their chief medical officer. I asked him what he was proudest of in his work, and I just remember that conversation so well. He answered without hesitation. Here's what he said. He said, "This year, I went to Parliament after the budget, and I asked that they take back some of the funds, millions, that they had allocated to healthcare, and please to redirect that money to the housing authorities. I knew that that would have a bigger impact on respiratory diseases than anything I could do with the money." That's what I'm talking about. Recognizing that the need transcends our narrow self-interests. Salve health. I remember also one night, many years ago, when I was a young doctor in training covering the ICU. I told this story before. A woman with severe diabetes was there. She was dying from ketoacidosis. As the evening passed and the night darkened, her blood pressure fell lower and lower. The acid was building up in her bloodstream and it was weakening her heart contractions. The senior doctor worked with me very late into the evening, but we were losing, and finally around midnight, he gave up. He said, "Call me when it's over," and he left to sleep. I didn't. For some reason, I stayed. Sometime around 2 in the morning, a thought came to me. I had heard a lecture that week about a different kind of acidosis than this woman had, and included mention of a very unusual drug, one I had never used before. And I glanced into the crash cart by the patient's bedside, and to my surprise, there was that drug, that very drug that had been mentioned. And so I picked up the vial, and with the nurse, we gave the drug. I don't remember the lady's name. What I do remember is watching her blood pressure rise, and then her waking up, and then her sitting up in bed the next morning eating breakfast when the senior doctor came in, fully intending to sign her death certificate. Instead, he wrote her discharge orders. What kept me at that bedside that night? Why, exhausted, and I was exhausted, did I keep trying? Salve Lucrum, not on your life. Not an iota of my energy, not a particle of my will had anything to do with payment or incentive or reward or punishment or requirements or praise or blame. It was much, much simpler than that. much deeper. I was there trying to do whatever I could do to help in a job that I was very proud to have. And that story is truly not about me. It's about us. It's why Jason Leach worked 600 days in a row without a day of vacation trying to help his country. It's why Manny Oliver and Adriana Pence and Chetan Satya, looking past their grief and their anger, took time to come together to encourage the changes they want to see in the world. It's why Kader Mate is devoting his life, his professional life, and his leadership to making equity a reality. This is about us. It's about all of us. I have never doubted that the vast majority of the colleagues that I am privileged to work with, and every single one of you, are not a whit different from me or from them. A healthcare world that forgets that pivots on money, that glorifies money, profit, lucrum, damages the only chance we have for rescuing the soul of something that I fear is very much at risk today and very, very precious indeed. We can do better than that. We are better than that. Let us take back control and make it so. Thank you.